The doctors would be glad to take your questions.
If I could, is it possible, and I know different regulations and all that, but could you give us a little more on Dr. Sacra's condition? Exactly sort of what the symptoms are, how he is on a scale of 1 to 10 in terms of his condition?
Yes, I'm really not at liberty to share any specific details. What I can tell you is that he did arrive safely, that we're doing our basic checks on him right now with getting some of our baseline laboratories, making sure that his fluid status is equilibrated, that his electrolytes are in control, those sorts of things. And I really can't share details on that, I'm sorry.
Could you give us a status, serious?
We know that he's seriously ill with a virus that has a fairly high mortality rate associated with it. Like I said, we will continue to care for him with very aggressive supportive care, and we're looking into alternatives for some of our experimental therapeutics right now.
Doctor, if I could, what is the toughest part of this treatment? What is the thing that concerns you most about a patient like him, if you can't specifically comment on his condition?
Well, the thing that concerns all of us the most is we have no specific therapeutic modalities to treat this virus. And so we're going to be using aggressive supportive care to support his organ systems, fluids, electrolytes, etc. We'll try to make sure that there's nothing else going on with him. And then we will be exploring our options to see what sort of experimental therapeutics are available. And we'll be looking at those and trying to figure out which one is the most promising and potentially using that for our patient.
Can you tell us what your options are on that one?
Well, there's a number of things that are being considered. There's the possibility that we could use passive immunity, so taking antisera or immune globulin preparation from a surviving patient and potentially using that. There are some experimental therapeutics that have been devised that try to trick the virus, if you will, sort of an interfering RNA molecule that's in development. There's also nucleoside analogs that are in development. All of these have not been used in humans. There is some promising data in animal models and primates. So we're going to look at that. We're talking to experts around the country that have started to do some of this work, and we'll be trying to figure out if this provides an option for our patient.
What is the point you have to make that decision?
We'll be making that as quickly as we can.
Dr. Khan, you talked about you expect more patients. Any projections as to how many Ebola patients will be coming to America?
No, you can't make those projections. I think the bigger point is that...
We're good.
Are we good? Perfect. I think the real issue is not projection on cases here in America. It's how do we stop the outbreak in Africa, and how do we scale up what needs to get done to stop the outbreak.
How many worldwide? Any projections?
No way to make a projection. What's clear is the outbreak is complex, difficult, and cases are increasing, so we need to respond.
And how does the outbreak stop? Does it just stop through people just avoiding other people with Ebola and it just sort of dies off? I mean, is there a way to stop this?
Absolutely. There's nothing new about this outbreak. The outbreak currently is a lot more complex than previous outbreaks, given where it's occurring. It's occurring in a place that's never had an outbreak before, so the medical community and the community aren't very familiar with Ebola. It's occurring in a complex set of very urban areas and extremely rural areas. And it's occurring in a place that really has a devastated health system and public health system. And you compound that with the fact that there's really a lack of trust, but often between the community and healthcare providers, which is and the inability to stop the outbreak to the current date. And this has really been exacerbated by years of lack of attention to health issues. And that's led to violence and other issues. So that's why this outbreak is a little bit, or in many ways, very different from previous outbreaks, why it's the largest outbreak ever reported. I think this is the most deaths that have ever been reported. However, the disease is the same, and how to get this outbreak in control is the same. It's about good public health measures, case identification, isolation, health communications, good infection control within healthcare settings. So they need to stop transmission within hospitals. They need to find every patient. They need to track every contact.
Dr. Sacra wasn't even treating Ebola patients, is that right? He was doctor treating pregnancy.
Yeah, I'd be glad to answer that. Yes, he was treating obstetrics, so he was giving birth, helping women through C-sections, so forth. so he wasn't treating Ebola patients. We're working with the CDC, who's on the ground in Monrovia. We've been cooperating with them over the last 2 months. For SIM, we would actually like to know what is that contact point, because as Dr. Khan has said, when we know that contact point, then we can inform others so that we better understand the situation. So we have no confirmation on the contact point.
Dr. Rupp, in terms of getting recovery, what does the progression of symptoms look like if the patient is able to make a full recovery?
Well, we would anticipate a course similar to what our colleagues saw at Emory, that we know we're in for a long haul. This might be a 2 or 3 week period of time that our patient goes through a convalescent period of time. We know the natural history of Ebola virus. Again, the incubation period being somewhere in the neighborhood of from the shortest time of 2 days, maybe to as long as 3 weeks. Folks come down with a constellation of symptoms consisting of fevers, headaches, nausea, vomiting, muscle aches, more or less a very severe flu-like illness. In the worst situations, they then have superimposed hemorrhagic symptoms where they start to bleed from the GI tract, etc. We're not seeing that in our patient currently. We'll be monitoring closely and supporting as aggressively as we can.
Dr., the other 2 patients made what I think most people looking at this from the outside see as remarkable recoveries, given what we've heard about this particular disease. What have you learned from those 2 cases that you can apply now that you think might make the difference? And are you optimistic about recovery at this point?
Well, I think you can look at the data coming from West Africa, where the mortality has been somewhere in the neighborhood of about 50% or so. That's in, as has already been related, fairly primitive, supportive conditions by our own standards. So these aren't hospitals that have ICU capacity and some of the capabilities that we have here in the United States. We would think with that supportive therapy that our patient has at least a good, if not much better, chance of survival.
Generally, are you optimistic about a full recovery at this point, given where we are?
Right now, I think we'll have to withhold comments on that. Obviously, he has a very serious infection. We know that this can be associated with mortality. We're going to very aggressively support this patient and hope for the best.
Doctor, can you talk a little bit about the number of people that are in a room at any point in time with him, the type of specialties they have, whether it's nurses?
Sure. So as previously was mentioned, this unit has been in existence for almost a decade. So we've been planning for this day for a long time, being very careful and very meticulous in that planning. We've been having drills on a quarterly basis for years. In recent months, we've obviously been stepping that up, thinking that this eventuality might occur. So this is a unit that's constructed, it's secure, it's separated from the rest of the hospital, it has a separate air handling system. The air is of negative pressure, so all the air is withdrawn back into the room. It doesn't escape back out of the unit. It's passed through a HEPA filter and exhausted outside. There's no recirculation of air. We have an autoclave within the unit, so any medical generated waste would be autoclaved before it would come out of this unit. There's a dunk tank that's filled with antiseptic so that if there's a laboratory test that needs to be done, we can actually take the vial and disinfect it as it comes out of the unit. So it's a very, very well thought out process. As far as the training that's been done, as has already been mentioned, folks have gone through a rigorous training procedure. We work with sort of a buddy system so that there's a person that helps another person put on their isolation garb, very carefully making sure that we're meticulous, that we don't miss any steps. And likewise, when they come out of isolation, the person's there to help them take off their garb and make sure that it is done safely. We have both an antiseptic shower as well as just a sanitary shower for people coming off of the unit. So every measure is being done to take care of this patient with the greatest amount of safety for our healthcare providers. Again, we think this is above and beyond what is probably required. As Dr. Khan has related, it's fairly likely that we will see patients coming from endemic areas of the world and presenting with febrile illness, whether we know it's Ebola or not. In our situation, we know it's Ebola, and therefore it makes it a much safer environment. When it's a febrile illness of unknown etiology, this is where it gets a little bit more tricky, and obviously hospitals all over the country are thinking through this eventuality and making plans for it. I'm in close contact and communication with my colleagues all over the country, and every major hospital in the U.S. is thinking of plans of how to safely deal with this kind of patient. Again, when we know it's an Ebola patient, we have this unit, it makes great sense for us to be using it. This truly is our mission, to take care of sick patients. It's also our mission to learn from this patient, and so that's why it's great to be in this environment at a university medical system where we can be looking for the best ways and the safest ways of caring for this patient. So everything's being done very methodically, very carefully, in a safe manner, and I think this is exactly the right place for this patient to be.
I think Dr. Russ Morris, in regards to the community, you mentioned the community reaction. They found out that Dr. Sacra was being brought here. Can you elaborate a little bit on that? What have you been hearing from the public? Obviously, in Atlanta, there was that concern that why are they bringing those patients here?
So I think first and foremost, we needed to communicate internally, and that was amongst our leaders, amongst our staff, and then our patients that were actually in the hospital yesterday afternoon, that the information was already becoming quite public, and we wanted to make sure that we were very proactive about communicating what was happening and reassuring folks and answering any questions that came up. So that was our first sort of touch point, if you will, in terms of how the reaction or any feedback that we were receiving, and across the board, comments like, of course, this patient would come here. Definitely we can not only provide this level of care, but outstanding care to meet this patient's needs. So that was the internal feedback. I also want to give a thanks to Emory, because related to communication and feedback and what could you anticipate both positively and any concerns, they shared some best practices that they had identified, particularly with their patients and families that were within the hospital setting. So we also have our internet sites, and so we're receiving a lot of posts and blogs related to that, and our fabulous media folks are monitoring that information very closely. And again, the outpouring has been, we're here to support, we think what you're doing is great. We understand that there are always going to be concerns, but we're appreciative of the feedback that we've received thus far.
Dr. Rupp, if you could, another question, related question we're being asked, and Dr. Sacra touched on this briefly last evening, is why here in Nebraska as opposed to sending Dr. Sacra to Emory? And can you talk about the government's involvement in that decision?
Sure. So we were requested by the Department of State to care for this patient. This was passed through the various mechanisms and was agreed upon by our own state health department. And I think the rationale is actually very sound. As we've already related, this is going to be a big outbreak in Africa. It's going to go on for some time before we get control over it. There are going to be patients that show up on our doorsteps either with known or perhaps having Ebola. And so it makes sense to try to improve our infrastructure for caring for these types of patients, making sure that we have centers of excellence that we learn from. And so, again, building our ability to care for these folks by using the various units that we have at our disposal makes great sense. And from that experience, translating into practice in other settings throughout the country. So again, it's very likely that other hospitals will see these types of patients eventually, and we plan on learning from our patient, passing on those best care experiences to them.
So basically making sure everyone with a biocontainment unit is up to speed.
Well, I think, yes, it's partly to make sure that these units are functioning like they're supposed to, and learning and, again, not overwhelming the capability in any one place. So again, this is something that I think we're in for perhaps a longer haul than we may have initially thought about, and it probably will go for some time.
Dr. Rupp, talk about the virus itself. You say you can only catch it if you human contact. But what kind of life expectancy, if any, does a virus have if it gets on, like, the ambulance that transported him here, or the suits that the medical staff is wearing, or any medical equipment? Does it have any life expectancy after that? Is there a possible way that it can be spread other than just human-to-human contact?
So these things have been considered very carefully. Obviously, we thought about this as we transported this patient here, so they're in a special transport vehicle with special precautions being taken and very aggressive disinfection practices being taken. This virus is not particularly resistant to known antiseptics and disinfectants, so very much the routine disinfectants can be used and will inactivate this virus. It's also not particularly environmentally hardy. So in other words, if it's out there in the environment, it fairly quickly dies due to sunlight and drying. So it's not a virus that is particularly contagious or infectious. Again, as we've already stated, it's spread by direct contact with blood and body fluids. It's not airborne and not floating around in the air that we're going to inhale. So we feel very, very confident that we can care for this patient safely with the precautions that are in place. And we are obviously taking very, very special care with our disinfection practices, with our sterilization practices.
Mr. Johnson, Dr. Sacra is the second of your medical missionaries to contract Ebola. What precautions are your folks taking in the field, and how concerned are you in sending people out and keeping people out in those areas where the Ebola is present?
Yeah, well, we continue to put into practice guidelines established by CDC and actually exceeding those. So we want to continue to do that. We want to continue to learn, just as the Nebraska Medical Center wants to continue to learn. We want to continue to learn to be able to provide good practice. You know, what's interesting is when Rick became infected, and we had confirmation on that just this last Monday, one of our SIM doctors left within 24 hours to go to Monrovia, Liberia, to both care for Rick, check on him. We didn't realize that he would be evacuated so quickly, and then continue our care in our hospital. So, yeah, and that doctor, you know, again, knows the situation, knows the protocols, and was willing to go in, and we were willing to have him go back in.
We have, I'm sorry, we have some folks listening in on the phone. Do you want to finish that?
How many people do you have in the field?
We have 2 SIM personnel in the field in terms of from other countries other than Liberia, but we have 250 staff workers at ELWA. Not all of them work at the hospital, but many of them work at the radio station at the school and just keeping the generators and the water running because there's no grid there that can actually help to run the hospital, so we have to do that all ourselves. But there's many, many Liberian staff that are doing a wonderful job, not only in the hospital, but also in the 2 Ebola case management centers that are there on the Elwood campus. There's one that has 43 patients about 3 days ago, that's Elwood 2, and at Elwood 3, which is run by Doctors Without Borders and the Liberian government, that has 120 beds and maybe need to be increased to around 200. So I just want to confirm what Dr. Khan is saying, that this disease is somewhat out of control. But there is opportunities with good healthcare measures to bring it under control.
Okay, before we go to the folks who are listening on the phone to see if they have any questions, we had one more question back here, and then we'll come back after the phone questions.
The patient was transported from the plane to the ambulance and into the entrance via gurney.
Okay, we have some folks listening in on the phone, I think. If we would like to field any questions from those folks, fire away.
Hi, this is Julie Steenheisen calling from Reuters. Can you hear me?
We can.
Great. What I'm wondering is if you can tell us who is paying for the transportation and for the care of these patients. Is this something that is handled by SIM, or is this the government or the hospital? Is, you know, just curious about that part, please.
Be glad to answer that. Yeah, SIM is assuming the financial responsibility for the evacuation. We're trusting that our good medical insurance will be able to provide the reimbursement for the medical center, as well as we're exploring our evacuation insurance to see if that's provided. All of our missionaries that go around the world. We send people from over 50 countries to all 5 continents, and those individuals have evacuation insurance for this kind of situation.
Can I just ask you to elaborate on that? I remarked this morning to you that you're getting pretty adept at these evacuations, which is both good, but also shows the level of risk that your medical personnel face when they go to countries like Liberia, Sierra Leone, Guinea, or other places. And you said that you're assuming the financial risk here. Is there a point, Bruce, where the liability becomes so great, not just from an economic standpoint, but from a personal risk standpoint, where you have to rethink having American medical missionaries in West Africa?
I'm going to ask Will. I sensed he had a response to that.
Yes. When our missionaries were evacuated, we evacuated a lot of non-essential personnel out of that. And then we've had meetings to actually assess the risk of people going back in there. And we're always continually looking at that. But one of the things I would say is, firefighters, when they have a fire there, they assess the risk. There's somebody in a burning building. Do they go in and rescue that person? Now, they've taken all the precautions they can to minimize that risk. And that's what we need to do if we've got medical staff going in there to minimize the risk that people take. There's always going to be some situations where you've done all that you can to mitigate against those, but something unexpected happens. And this is where we need to learn about those risks of unexpected. And as has been said, this is totally different in terms of the context of this disease happening in West Africa to other outbreaks. But we do assess the risks, and we talk with individuals about going in and the risks that they are taking. There may come a point in the future where we say, well, we can't actually take the risk of other people going in there. But our heart is with the Liberian people, with people who are needing the health care and who are dying from this disease. And we need to ramp up the international response to the Ebola crisis that is happening in Liberia and in the rest of West Africa. We can't just stand by and do nothing in that.
Do you know what that point is?
I can't say at the moment what that point is. We assess it continually as to what that point is, but I can't say at the moment what it is.
Before we field any more questions, do we have any more questions on the phone?
Yes. Yes.
Okay. The gentleman who spoke first, go ahead.
Hi, this is Kevin Stewart with WAGA Television in Atlanta. I was curious, what were the most important elements that were learned from Emory University that they've shared with you? Is there anything that you learned that you will do differently?
Well, as was mentioned earlier, we have been in close contact with our colleagues at Emory. They were very forthcoming with sharing their experience. They talked a little bit about some of the practicalities of using some of the isolation gear and how to do that more effectively and efficiently. We've taken those things in advisement and are looking at our own practices here. So I think those are the types of, perhaps everyday mundane sort of tips that sometimes are the most valuable. And we've clearly, been listening very, very closely and trying to mirror our practices to make use of their experience. No, there were no surprises to the best of my knowledge.
We had one more question. Excuse me. Go ahead, Brian. Finish that one.
Yeah, I can't really share specific details on the condition of the patient. Suffice it to say that, again, the transfer went very smoothly. Patients in our unit, we're evaluating him, getting baseline measures right now, and stabilizing him. I'm not going to be able to share specific details on his condition. I'm sorry.
I think we had at least one more question on the phone.
Hi, can you hear me? This is Carrie Sheridan from AFP.
Absolutely. Go ahead, Carrie.
Okay, thanks. I was wondering if you could tell us anything more about the latest on the hospital where the doctor got Ebola. Were there any other patients there in the obstetric ward who had Ebola, or how is that being tracked, and what's the latest on that?
Yeah, I'll respond to that. No, we don't have any other patients in the hospital that have Ebola in the actual hospital where they're treating obstetrics patients, and we're hoping to treat pediatric patients. But there are many patients in the Ebola case management units. As I've mentioned before, we had about 43 patients just a couple of days ago in one of the units and up to 120 in the other units, but no Ebola patients actually in ELWA hospital. One of the issues that we're facing is that many of the hospitals in Liberia have closed down. Many of the staff are not there. They're fearful about coming into work. And there are people there who are dying from other diseases other than Ebola, such as malaria and typhoid. And there's mothers who need to go to hospital to have their babies, and there aren't the hospitals necessary that can take them. So that's becoming, in a sense, as much of an issue as the Ebola crisis itself.
And this is, again, a real good reminder why we should be heeding WHO and CDC advice to sort of ramp up this response and help get this outbreak in check, because not because of the challenges there in Liberia, which is where everybody's heart is, but again, every global problem is a local problem.
Dr. Rupp, do you know, can the other two Americans who've recovered be able to this patient?
Again, as I mentioned, we're evaluating the possibility of using serum from the recovered patients. They would presumably have antibody formed against the virus, so we'd be able to use that preformed antibody and give it to our patients. So that is one possibility that's being evaluated. Well, so for example, in some of the more primitive settings where care is sometimes being delivered in some of the poorest parts of the world, they may not even have the capability of giving intravenous infusions. Sometimes they rely upon just oral rehydration therapy. They aren't able to give patients electrolyte infusions. They can't give patients medications that would support their blood pressure, let alone put them on a ventilator. So these are the kinds of things that we'll be able to do in this unit. And again, I think tries to shift the balance in favor of our patient.
Doctor, based on your assessment from your colleagues, how important was this experimental drug ZMapp in the other two cases, and how concerned are you about not having it now?
Yeah, so it's really impossible to say with such limited experience how effective this medication is. I think that many authorities believe that it's the medication that's the furthest along in development that shows promise. Clearly, it's been given to a number of folks. The two patients here in the United States survived. I'm aware that it was, I believe, given to the physician that went to Spain and died. So, we hope that it's helpful. I know that they're working very hard to develop additional doses. And as I mentioned, this is an opportunity, even though it's a big tragedy, for us to learn more about this disease and more effective ways to treat it. Clearly, we want to be using these experimental drugs as a responsible manner as possible to learn the most that we can.
Has the patient been, is he responsive? Is he communicative? Has he said anything that you might be interested in knowing about? Can he ask for anything? Express any thoughts?
Do you want to share with it?
What I will share is he is communicating with us. Thank you.
Has any effort been made to contact those survivors and do that sort of that's a new?
Yeah, again, we're evaluating our options at this point. That's about all I can say.
The virus itself, does it remain dormant in the body? No chance of it coming back like a herpes virus will come back periodically. Once it's gone, it's gone. Is that the case?
That's correct. Once somebody survives their illness, they're thought to be immune to the disease. They will have antibody there that's present and should be protective. The virus can remain in certain body fluids for some period of time, and so there is some concern that it could be in seminal fluid, for instance, for a longer period of time. So these are the things that populations need to be aware of and take precautions for. This is one of the worries in Western Africa, that you may have patients who survive then could potentially, for a short period of time, we're not talking years by any means, but for a number of weeks, could potentially have some infectious virus in various types of body fluids. But once they survive, they're really immune, and the virus does not hang out like a herpes virus, your example. It will not come back and remain latent for long periods of time.
Since Tom has brought up herpes, that probably is an indication that we're about ready to wind things down. Two or three. Leave it to Becca to do that. 2 or 3 more questions, and then we'll call it a day here.
I'm curious, Rick, just kind of women who are going through what has this whole process been like for you, even on a personal level?
Yeah, on a personal level, when I read Rick's email Monday morning, you can just tell by my emotions that I had the same response Monday morning. Some tears, emotion, taking a deep breath, realizing this, had the possibility, but it was Labor Day. I was trying to, relax and be able to restore myself. And honestly, it took the wind out of me. But at the same time, I have seen God's faithfulness with Kent Brantley and with Nancy Wright-Bowl. And so my faith held sure. It was actually then Monday afternoon, I was standing in the line with my wife. We were buying an appliance, and I was in the checkout line when I looked at my text that he had tested positive. And so Will and I and the rest of our leadership activated a rapid response team, and the team has just responded and has really pulled together, on our side, and then being able to see all of the different people that have responded to be able to bring Rick back has really encouraged our hearts. But even this morning when I saw Rick being transported into the hospital on the ambulance, I'm sitting there crying. But tears actually of gratitude that he was able to come back and care for him, and trusting God for a good outcome, and trusting God to use the good medical staff here, whatever treatments, God uses all means, and we're praying, just as Jim, my new friend, who served me breakfast this morning, activated a whole prayer chain for Rick.
You talked about Rick being kind of a humble guy, but can you talk a little bit more about what he's like?
Yeah, I've known Rick since the year 2000 when we were both on the same SIM leadership course. And I've known him off and on since then. I've been in Liberia for 4 years as the country director, and Rick has been in and out. But he's been in Liberia for upwards of 25 years. He was working all through the civil war that was there. He's been evacuated twice because of that out of Liberia. But he's a guy who loves the Liberian people. And just the team of people that I work with in Liberia, not only the SI missionaries that are there, but also our Liberian colleagues, are fantastic people who are dedicated to serving those that are around them and giving the glory to God. So I think for Rick, as Bruce has shared, he's a humble guy, and he apologized for what was happening. He wants to see the ministry of SIM continue there. We're at the moment, in partnership with Samaritan's Purse, we're building a new hospital there to replace the rather dilapidated one that we have. And as Dr. Kana said, the public health system in Liberia needs improvement, and that's part of what we're about, working with partners in order to be able to do that. And part of Rick's commitment is to go back, Lord willing, if he survives, to help to set up a residency program for training Liberian doctors. We want to improve the healthcare system in Liberia, and that is urgently needed at the moment.
Time for one last question.
Dr. Rupp, can you talk a little bit more about the possibility of using the convalescent serum from those previous survivors? Do we know anything about possible risks of doing this, side effects, long-term effects, and things like that?
Yeah, so the basis for this is, again, somebody who's recovered from the infection would have antibody formed against the virus, and we would be using that passively. So in other words, giving that antibody to our patient. Again, we're evaluating whether that's going to be possible, and that's really about all I can share with you at this point.
Okay, that'll wrap up things here this afternoon or this morning, whatever time it is. This will be our final official briefing for today. We are still in deciding mode whether we'll have something tomorrow. It's very likely